Good afternoon. My name is Dr. Jim Buehler. I'm a clinical professor and interim chair of the Department of Health Management and Policy at the Dornsife School of Public Health at Drexel University. Welcome to our seminar today, our webinar today, which is the latest in a series of webinars that the Dornsife School of Public Health has offered over the past month or so that address different dimensions or aspects of the coronavirus epidemic or pandemic. The past sessions are all archived. They're available at drexel.edu/Dornsife, D-O-R-N-S-I-F-E, and you can just click on the coronavirus tab to get all of that information, as well as information about next week's seminar, which is going to focus on misinformation and the role of risk communication in the COVID-19 pandemic. That's next Wednesday. Today, our theme is the connection between emergency medical care and public health. Public health problems often manifest themselves among people who visit hospital emergency departments. We've seen this among patients with opioid overdoses, gunshot wounds, or symptoms of COVID-19, but many other public health problems show up or manifest by people who need emergency care or who seek emergency care. Public health departments recognize the importance of transit emergency department visits as an important barometer of the health of communities, and many of them track electronically data on ED visits on a daily basis as one measure of the health of the communities they serve. There's also growing interest among emergency physicians in taking advantage of the occasion of ED visits to address broader concerns among their patients, within, of course, the constraints that are imposed by the primary objective to provide emergency care. But this includes doing more to assure connections between ED care and follow-up care and community services. And this session will feature two panelists who are both emergency physicians whose career exemplifies efforts to integrate the perspective of emergency patient care and public health. Our first speaker will be Dr. Priya Mammen. Dr. Mammen is an emergency medical physician and public health consultant. She's a fellow at the Lindy Institute of Urban Innovation at Drexel and currently serves as the chair of the section on public health and preventive medicine at the College of Physicians in Philadelphia. Her interest in connections between emergency medicine and public health has spanned HIV, the opioid crisis, and now COVID-19. Dr. Mammen will offer her perspectives on the ED and public health connections in the COVID-19 era based on her firsthand experience in the emergency room. Dr. Theodore, or Ted, Dr. Ted Corbin, is an associate professor in both the departments of emergency medicine at the Drexel College of Medicine and the Department of Health Management and Policy at the Dornsife School of Public Health, where he co-directs the Center for Nonviolence and Social Justice and serves as the medical director for the Healing Hurt People program. This is an ED-based program that identifies people who have suffered from intentional injuries and works to engage them in recovering and provides a variety of supports as they recover, not just from their injuries, but seek to re-enter their communities. Dr. Corbin will be talking about the intersections of violence, racial disparities, and COVID-19. So with that, I will turn the program over to our two panelists. I've asked them each to provide some opening comments for about 10 minutes. Dr. Mammen will go first, and then we'll have an opportunity to address your questions. So Priya, you have the floor.
Thank you so much, Dr. Buehler, and thank you to the Dornsife School of Public Health for having me as part of this webinar series. I can't adequately articulate how exciting it is for me to be a part of this with two of my personal heroes and mentors, Dr. Buehler as well as Dr. Corbin. I've sort of been fangirls of their careers from afar, and am very lucky to have them as ongoing colleagues and mentors. So to be a part of this and discuss it together, something that is very near and dear to my heart, which is emergency medicine and public health connections, is particularly thrilling, so thank you. Just as a bit of background, I'm an emergency physician, but I started my career in international public health before I decided to go to medical school, working in systems development in war-torn countries, particularly Cambodia, in the mid-90s or so. And it was really, ironically, my experiences of systems development and working to improve an overall health system, and being frustrated that we weren't able to address immediate health needs of the people we were trying to serve. And so that's what sent me to medical school, with the idea that I would learn how to take care of people in the immediate, but really public health was the mindset, the thought process, and the approach that I think I always felt was more near and dear to my heart, but also more aligned with what I saw as my personal missions and kind of goals. So in the middle of my medical training, more and more, I recognized that emergency departments are unique in our healthcare system as being the only part of our system in the United States that is truly universally accessible. And the rules of engagement are, in fact, triggered by the user end, which is not the same as other parts of the health system, which is somebody decides they need us and they can come to us. And the only other barriers beyond that are if they are the sickest. So the way triage work is the most acute, the sickest, the most in need kind of goes to the head of the line. And if, they're willing to have unscheduled care. But what we've seen, certainly since the time I started medical school to now, is that has become more and more and more important. We don't have the same barriers of other parts of our health system, which including, do you have insurance? Do you have an ability to pay? Have you been able to fit this into the way we work, as opposed to we kind of fit into the way other people decide to access care. And so it has more and more over time just been a reflection in my mind, and I think highly recognized now, of a place where the needs of the community and the needs of a population become really apparent very quickly if you're looking. The flip side, so as a clinician, we're trained on these one-to-one interactions, and as skilled emergency physicians, our skill set goes into addressing a specific need. But for those of us who are trained in public health and those of us who kind of have that paradigm as part of our intellectual infrastructure, over time, several individuals together, you sort of see patterns coming out. And I think both Dr. Corbin and I have had the experience of seeing patterns that are just not going away, and are recognizing that we can fix a problem to some extent. Or we do our best to fix every problem that presents right in front of us. But unless we or somebody else or the system addresses the problems before they get to us, it's just going to continue to be an unmet need and an unmet issue. And so over the course of my career, that's basically what I've done, is used the experiences that I have as a clinician, and used the stories of the individuals I see and treat to really highlight needs that our health system may or may not be addressing in the most meaningful way. And then trying to find ways to address those, mainly between partnerships. And that is kind of working outside of the silo of the emergency department, outside of the silo of the health system, but really all of our colleagues and community members who must be part of any meaningful and sustainable change. We all have to do it together. And so That all comes from public health, and that all comes from the skill set and the evidence-based approach to public health as a science, and not just as what I think prior to COVID was often recognized as just sort of like a nice way to think. There is hard science and there's hard data and there's evidence-based approaches, and what COVID has done is just highlight how critical those processes are and those partnerships are and the infrastructure is. And it's also another way of showing what the emergency department and frontline providers do. So I find that I feel a little awkward. And one of my colleagues, actually, Dr. Megan Stobart, was quoted in the Inquirer just today and she said what I think a lot of us feel. It was like, I don't really feel like a hero. This narrative of frontline healthcare providers being heroes is awkward, and we're really doing what we're trained to do, and we're doing what we love to do. But it's the ability for other people to kind of recognize the opportunities that we have to help and serve our individuals, but also the community as a whole by being there for their needs. And that paradigm is it's easy to kind of assume that the entire health system works like that, but the reality is that it doesn't to the ideal sense, whereas emergency departments do. So that's just a quick summary of my thinking and my approach, but really how important public health is to the clinical side in terms of making meaningful improvements and change.
Great. Thank you very much, Dr. Corbin. Ted.
Good afternoon, and thank you and Priya for this time together to talk about a really, really important pressing issue that in some spaces, certain schools of thought don't actually think that it's actually public health. Like Priya, I was drawn to emergency medicine in part because it's that one space in medicine that has the flexibility and the obligation to serve anyone who comes in for care. And in that process, it was where I recognized that, to Priya's point, where there was a pattern of something that was evolving, and that was that of interpersonal injury, which was seen mostly among marginalized people, even more specifically, boys and men of color. And the status quo is such that, medicine is amazing. We're able to stitch folks up, suture them up, take them to surgery, discharge them within a day or two, but we don't pay particular attention to those deeper wounds that folks experience. And so that's what drew me into violence intervention and recognizing, identifying young people, anyone who's come in as a victim of interpersonal injury, and connect them with the resources so they don't end up back. Because sadly, in my career, when there is an absence of such services in place, the young people, consistent with the literature, either come back shot or stabbed again or dead, sadly. And so when we look at that and we look at just the overall health disparities of marginalized population, it's really heartbreaking. And so our efforts have really been to have a team of people connected to emergency departments and trauma divisions to identify young people that have been shot, stabbed, or assaulted, and connect them with our team of community health worker peers and social workers. So there's a component of delivering peer support services, case management, as well as counseling, so that we can really tap into the dire issues that present themselves that young people aren't always inclined to disclose. But we have an amazing team of individuals that are able to do that. And then you see the issue of violence, you see the issue of disparities and racism and oppression, and then here comes the pandemic. And it just makes everything that much more apparent. These are not new things, sadly, but it really does highlight. It's sad and terrible that the majority of the populations in Philadelphia are people of color who have tested positive for COVID-19. But then when you overlay those areas, and I'm sure there are people that have been doing it, and we're in the process of looking at our clients, we see that these communities are hugely impacted by violence, they're impacted by racism. They have their income level is $35,000 or less. And it just really presents the lack of fairness throughout our community and throughout our society. So as much as I think we're doing all that we can do to address the issues of the pandemic, we're also trying to address those issues around violence and violence intervention and trauma. And they have some similarities in terms of the lack of access to the appropriate care, the lack of trust in certain systems because of the historical letting down that those systems have had on individuals. And so I think it's imperative that we pay attention to these intersections of both disparity and public health problems. Priya has been really modest because she's an amazing physician, but then she's also done so much in terms of the issues around the opioid epidemic. And again, that is still happening. Just as the violence issue is still happening. I looked at the most recent statistics, and the number of homicides is 15% more than it was at this time last year. And so the violence hasn't gone away. The disparities in who it affects the most has not gone away. And I just urge folks and people, public health researchers, the medical practitioners, that we continue to pay attention to that in the eye of this pandemic.
So thank you very much. Let me pose a question. I think historically in the old days, the way people looked at ER care, ED care, is you came into the ED, you got the immediate problem taken care of, and told go see your doctor in a week or for follow-up. But now both of you are talking about building connections from what happens in the ED to follow up. I know, Priya, you've been very interested in that around the opioid situation. How is that playing out with COVID-19 in terms of you've seen a patient and are getting ready to send them home? How is your practice dealing with the needs for follow-up that people with COVID-19 might have?
So it's interesting. I would say the perception may be that we work clinically in isolation from our partners in medicine, but that's not altogether true. We try as best we can to make sure to facilitate connections and referrals and appointments, particularly for those who turn to the emergency department because they feel like there's no other place to turn. And what I've learned from my work addressing the opioid crisis is really our system is just so difficult to navigate in so many ways. And I would argue, I'm arguably among the most health literate. I am a part of the system, and even for me, I thought this system, I cannot understand how to get from one place to another. So a lot of what we do in the emergency department is not just that piece, but really trying to make sure that we're connecting patients to what they need. In the setting of COVID, what's very different is that offices are not open in the same way. And so it is actually quite difficult to understand and figure out what services are available for follow-up. In the situation of COVID, the other thing is, this is all, we're 2 months in, but it's very, very new, and information and data and evidence changes almost daily. And what it's changing based on lived experience, literally, of physicians and caregivers within the scope of this, right? And our entire population is in shutdown to some extent. So to figure out how to navigate is even more difficult. What is particularly salient for me is we send people who are not very sick home. And we still don't have the ability to test every single person. And so we test people for whom the information matters. And that it becomes a public health issue more than a clinical issue. So the clinical diagnosis of COVID is based on symptoms and is based on potentially known exposures and all of that. Where our testing paradigm comes in is for people who are so sick that they require ICU level care. It's to make sure that it's an information point, but it's also to make sure that we're not missing anything else and to sort of use resources appropriately. But we're not testing the people who are well enough to go home who we clinically suspect have COVID. What has happened is now we have changed our testing paradigm to say we're testing people for the public health data of where these outbreaks are coming. So we can say anecdotally, it's not anecdotally, but it's clinically based that someone has a presumed diagnosis of COVID. But I work in the collar counties, and whereas in the city we have a certain understanding of where people live and how dense that population is and things like that. In the counties, people can live much further apart, but the same discharge instructions. My instructions to someone as they go home with presumed COVID is isolate for 14 days, and here are the things to look out for, and here are the things that we want you to be concerned about, and come back and see us if any of these things happen. But I'm also working with rural workers and those who work in confined spaces like factories and for canning products, and farmers and farm workers. And so I know that those same instructions are not meaningful for people who live in multi-generational homes and who have, just by definition, have elderly and have children and cannot physically isolate within their home. So it becomes even more of sort of a point of anxiety to me to not know who and how to look out for them a little bit more. But the testing part goes in. So at least if I can test them, then the bigger sort of purview knows to look in this area, because there's no question it's going to spread among those people just by their living situation and just by contact. So at all points in the emergency department, we're acutely aware of one size doesn't fit all, but we actually see the full breadth of our communities and societies. We see all socioeconomic status, we see all age groups, right? So it gives us the vantage to be able to see population-wise like snippets, but also know that we have to be a little bit more protective and exhaustive in how we address the needs of certain groups compared to others. But again, within the COVID shutdown situation there are telehealth availability for checking in on people, but not all patients have access to that kind of technology. We've seen that with our children in Philadelphia school district, right? The school district gave children computers and access so that they could continue to learn. We don't have those kind of mechanisms in the world of medicine. So it has most definitely made me very aware and concerned, and pushed me to try and articulate that to the policymakers and the decision makers and the hospital systems of we really need to be able to be more protective. And we have limited resources from the emergency department, but we're also tend to be the only ones seeing a lot of these people because offices are closed and they can't log into a telehealth company, right? So it's been difficult. It's been concerning. And I can say a lot of people are listening. We just don't have all the answers just yet.
Yeah, do you want to follow up on that? Perhaps how has this affected the ability to provide the services that you provide, or how's it affected the need for the type of services that you provide?
Sure. And I agree with Priya completely. Where our team comes in, and I think it's a team that's been probably around for many years, but not necessarily utilized to their fullest potential. We have a team of community health worker peers, and these are young people that are from the community, that are given skills around some of the basic things around community health, around peer support, around behavioral health, and we have social workers that are skilled in delivering counseling and evidence-based therapies to our young people. And we've had to flip to a telehealth platform because, of course, you want to minimize the amount of people and the amount of contacts, and so they are not deemed as essential personnel to go into the hospitals. But I would say that at the same time, the seriousness and the gravity of the pandemic has not stopped the violence by any means. And so we rely on the referrals, and we continually encourage folks to refer folks. And those young people, or those people that are impacted by violence, are also the same people that are in those communities that have a really high rate. I kind of took a glance at our data, and I looked at where the majority of our clients that are involved in healing hurt people, and I noticed that at a rate between 75 and 156 per 10,000, that's where our young people and families are. And so that's pretty high. And so we want to pay attention to that. And so our efforts have really been to connect virtually by making sure that we have the appropriate referrals in place. And I think it's key. I mean, even beyond COVID or post-COVID, and I think you heard it in what Priya was saying, is that making the connection for the appropriate follow-up care is imperative. And in some instances, it's not going to be me, it's not going to be Priya, it's not going to be anyone staffed in the emergency department. Ideally, it would be a community health worker who is able to go into the community where there's a level of trust, there's a level of understanding and ability to navigate those communities, so that we can help our communities heal from not just the trauma, but also the concerns and questions that they might have about COVID. Because there are some myths out there too.
I'm sorry?
I was saying there are some myths in certain communities, different communities, about what COVID is, how it presents, and what it could do.
So a question from the audience, could this apply to either of your experience? What about the patients that don't have an established primary care provider? What do you do in that situation?
Is this COVID specific?
It could be COVID, but or more general.
So in the city of Philadelphia, we actually have a pretty extensive public health clinic system, the health districts and health centers. And we do our best to facilitate connection there if somebody doesn't have insurance and a primary care physician. Certainly, if they are insured, it makes things easier to some extent. But it's really, this is one of the things. So way before opioid crisis, this is one of the things that I started to work on, was a way to have direct connections with the public health system. And, you know, I've kind of been sort of like, look at us to public systems, because we are perfect partners in a lot of ways. in not only sort of the data collection that you can get from ED utilization, but also the feedback of these are patients in need, and these are, and that's not just primary care. That's, you know, when I developed an HIV screening program out of the emergency department, sort of mainly because Philadelphia had one of the highest rates in the country of undiagnosed HIV. And so this is something that I think the health commissioner before you, Jim, Dr. Donald Schwartz, sort of brought to attention that Philadelphia had exceptionally high undiagnosed, untreated rates of HIV, and that it was being spread within communities. And in that case, it was people getting sicker from their infection, but also people inadvertently infecting others. And so where systems had been of, this is something that primary care physicians should be screening for, this is something that should be screened for in this environment, it doesn't acknowledge just that sort of CDC-based paradigm, doesn't acknowledge that some people don't have primary care physicians, some people don't have an access that is universal and sort of reliable point of care. And so in an urban setting with that kind of burden of disease that is undiagnosed, then it makes perfect sense for emergency departments to start being the ones, not the ones, but part of the system to try and find people, right? And what we have going for us is that we don't know our patients, they choose us, right? We don't have appointments, we don't say we're gonna see you guys and you guys only. Anybody can come to us. You can live in any part of the city, you can live outside of the city, and you can come to us, it's your decision kind of thing. And so that takes away some of what, you know, that I've seen, it's not recognized, but it's becoming more and more recognized. If there is an inherent amount of stigma or fear of doctors feeling that their patients will feel like they're judging them by saying, I'm going to screen you for HIV because there's something very bad about having HIV. But that's not the case, right? That's not, we as physicians should not be propagating those kind of ideas. This is just evidence, and this is the kind of testing structure. Whereas in the emergency department, it's easy to say, we test everybody unless you tell us not to. And so there's no judgment, there's no stigma, it's just very matter of fact. And, you know, over the course of time that I ran and directed and sort of developed the program, we tested, I feel like almost 90,000 people. And we diagnosed almost 300 people. So, and it wasn't just the diagnosis, we took the responsibility of linking those people to care, much like Healing Hurt People is not just sort of in this moment, it's like we are with you and we're going to help you navigate the rest of the system. And so it is a clinical intervention if you look at it at one point, but at its core, it's a public health intervention of recognizing where people may fall out of what is considered usual. And I would argue that there's no usual anymore. The way Americans work, the way our city and our city citizens are working, whether it's hourly wage working, people are working overnights a lot more than they used to 20, 30 years. It's a kind of around the clock structure, right? So that's what emergency departments offer. And we can really capitalize on that time and moment with people to sort of get a glimpse into the issues that a community is facing and a glimpse into why we're not addressing them appropriately in the traditional systems that we've always sort of relied on. The ED offers that kind of other perspective and other access to people in particular, but also as I've been trying to work for the last 15 years of just making us an automatically considered part of the public health structure of where all of the connections come into place. And that includes community organizations, and that includes our central city government in this case, and includes the health systems. Like we all just have to work in a different way. It sort of flips the paradigm a little bit. But if you think about it in a patient-centered and community-centered way, it makes much more sense. If you think about it in the traditional medical and health system paradigm, the biomedical paradigm, it perhaps seems like it's just an outlier, but depending on which population you're talking about, it's no longer. And I think in the state of 21st century medicine in the United States and the barriers that have been very clearly not just highlighted, but accentuated in the setting of COVID of who does have access to care and who doesn't. There's no question that emergency departments are still like right in the mix of it. And we offer, you know, what I would say, and granted I'm biased, but the closest to unbiased care, unstigmatized care. It's just, we're there to do what we do, whoever comes to us.
Ted, did you want to add to that? Or?
And I echo Priya's, you know, what she says in every way. And I also would add that I do think that connecting patients from the emergency department who don't otherwise have health insurance or even you know, access in some ways is really a gap that needs to be filled. And I think what Priya is saying, it's imperative that we have these relationships with the health centers in the city, as well as the primary care offices within the various institutions. I mean, because of this regionalization of medicine that is upon us, I think it's incumbent upon us as not just as providers of care, but it's important for us to ensure that our patients get care, because the goal is to keep them out of the hospital. Really, it really is to keep it, and we just happen to be that open door, that safety net for the community, for folks to enter. And so I think it's important, and I want to come back to, I think it's imperative that we invest and support community health workers to be a part of that. I think we're missing a golden or have missed a golden opportunity to take advantage of their skill, of the trust that they can gain or have gained from communities, and the reliability of them.
Thank you. I think something else I would add is that Philadelphia does have a very robust network of community health centers, federally qualified health centers. The Philadelphia Department of Public Health operates a network of 8 different centers. There are other organizations that offer that run community health centers that are intended and located to serve communities that otherwise are underserved by access to medical care. I know that doesn't solve all the problems, but I think it is a very important resource for primary care in Philadelphia.
So I have like one little thought to add to that. When I sort of refer to flipping the system, you know, it's easy as an emergency physician to flip the system to kind of center it around the web of possible resources. But part of that is also recognizing what requires medical level care, and where health and wellness intersect is not necessarily in a therapeutic, in, you know, the traditional biomedical paradigm, right? And so when Dr. Corbin talks about the community health workers, there is so much. I mean, if I say, in my mind, where EDs are the only place where it's like truly unbiased care, there is still bias. There's no question. I wish I could say that there is no stigma and no judgment, but I've worked with systems with homeless populations, systems with newly diagnosed HIV populations, and most saliently, the opioid crisis. And I can tell you our system is absolutely stigmatized and biased towards a lot of large groups of people, and they fear or they just don't trust, right? And hearkening back to how my career started, in low resource environments, community health workers and the systems of community level engagement is so critical. And the data overwhelmingly shows that you don't actually need an MD or an RN to be the most effective person in addressing someone's health, right? That has been very established data, mainly from international communities. And I think in the United States, we have not developed those kinds of networks as much as we could and should. And that's just nature in my mind of how our health system has been built and developed. But again, in the setting of COVID, we've seen all of the ways that that's not meeting the needs of our population, because as of right now, we have the highest unemployed rate, which also means we have the highest uninsured rate, right? We have hospital systems where, you know, and I'm grateful, but we have buildings lit up blue. We had the Blue Angels fly overhead, and literally the day after the Blue Angels flew over Philadelphia, I was reading emails from health systems where people were going to be furloughed and laid off because the health system isn't working the way it usually works, right? We're all in shutdown. And so that raises serious concerns, but also raises the importance of where the public health voice and, again, the science of public health, not just like this is how you think about large groups of people, but there is science underneath this paradigm and that drives it. And that those two need to meet, because we are at a moment right this second where we can either try and sort of hunker down and say, okay, we're just going to wait for this to be over. And in the process, all we're doing is ignoring even longer all of the things that both Dr. Corbin and I and all of our colleagues, and really so many of the researchers and workers in this space, have recognized for years that our system has not met the needs of everybody that it should be meeting. Everybody should be equal. And if we're saying that only those who are lucky enough in this shutdown to have a job that they can work from home and they can keep that job are worthy of healthcare, then we've failed without question. And I would argue we have been failing. It just is less noticeable because people could go to their work and maybe have insurance through their work, or it was easy to kind of assume that it was really just a minority who didn't have insurance and didn't have clear access. But the messaging is very clear from our system that if you can't pay, then we're not going to see you, and that's not okay. And so where we have to, in my mind, just use this moment in time. This is a crisis, and the crisis will only be sort of, it won't be averted because we're in the midst of it. We didn't avert. There's where public health, had we had like all of the public health experts, because the aversion, we missed it. We could have done something about it. We could have done all of these things, but now we really have to look ahead and say we cannot continue to allow these systems and allow these groups of people and these whole cities. I mean, our city is the poorest of every large city in the country. If we're saying that only some people deserve to have clear and unfettered access to care, then I think we've failed. I don't think there's anything to be proud of in that argument, right? And that's not just a clinical perspective. And that's not just a public health perspective, that's a clinical perspective, because everybody who shows up to an emergency department, you could almost argue, and I have, that it is a reflection of some system that has failed. And it's not the person that has failed, it's the system around them. We all live in a context that cannot be denied. And COVID, again, has just shown where that context matters so much in the health and wellness of a person and the health and wellness of a population. And so, I mean, I hate to sound so dramatic and maybe just overzealous, but I just feel that all of us who are public health, not even public health, all of us who are present right now, the task is in front of us to make sure that we do not continue to make the same mistakes, and we stay from this moment forward. We will not allow, it's not good enough to just go back to how we were, right? That will never be good enough anymore. It wasn't good enough before. We are at a precipice where we really can intervene, intersect the lessons and data and evidence from public health with the lessons and data and evidence of clinical medicine. And they have to merge to be able to build a system that will really be the most effective and efficient for our city, our region, our country, all of it.
Ted, did you want to add to that?
I would just say, I think we should just also be very poignant that the people and the population that we're talking about are Black and brown people that are suffering, and it's just time for the suffering to stop. And I just, you know, I think we're just one program among many that are looking at ways to engage folks tapping into their worth as a person of color to help their community heal from this, you know, these hundreds of years of oppression. It's deep, in my opinion. It's extremely deep, and so the medical institution is not void of promoting that oppression by any means, and it's really imperative that we look at it differently. And I think public health, I know public health is the way that we can move things forward.
Thank you. So we've got several questions that have come in the last few minutes. The first one is one I don't think we're going to be able to answer today, but I just want to acknowledge it. It says the anthrax attacks of 2001 gave us syndromic surveillance. So the threat of bioterrorism, investments were made in these automated systems of syndromic surveillance where we can track ED visits across the city on a daily basis. And the question is, will the coronavirus pandemic finally give us ED discharge data systems in Pennsylvania? I think this is an allusion to the fact that we have a database that monitors hospital discharges, but we don't have a comparable database for emergency departments as some states do. That's an important question. I don't think, I would say the answer to that is I hope so, but I don't think we're going to be able to answer that today.
My understanding is that the health department has been looking at respiratory disease from the emergency departments.
Yeah,
right.
And so I would also say, if it's able to do that, it's also able to do that for violently injured people, for opioid addicted people. I think it's so I think there's the example that it can be collected, and it's important to be collected. I think it's just a matter of ensuring those systems are intact and in place.
There is,
and I think
for the opioid crisis, they definitely, I don't know the exact mechanism, but they do track ED utilization based on syndromic or discharge instructions. So and I think this has actually gotten much better. And Dr. Kendra Viner sort of oversees this from the health department, but it was the interfaces of police, EMS, and emergency departments for opioid crisis, because all three are involved in overdose reversals anyway. But like they have built systems. One of the issues was how to communicate between those systems that should and can be very, very important to understand the bigger picture.
Right. The syndromic systems do collect data on everybody that comes in. It's very limited, no identifying information. So you should be able to adapt those systems to track whatever constellation of symptoms is, or diagnoses, at least preliminary diagnoses is of interest. So next question is, tell us a little bit about the protocol. What do you do in the ER when a patient with COVID-19 walks in? You may not know the patient has COVID-19, you suspect it. So what is the process for caring for a patient with COVID-19? Or suspected?
So we basically suspect everyone until there's evidence that it's less likely. But that happens in triage. Everybody who comes into the emergency department, it's now become that it's a given that people walk in with a mask, but everybody who comes into sort of the waiting room are given a mask for while they're there. They are triaged, and part of the initial triage, the sort of first set of questions is questions about known exposures and questions about symptoms. And if any of that lines up to being concerning for an acute COVID infection, then they are sort of isolated for very quickly in this case, to then go into a negative pressure room, which we don't have. You know, an entire emergency department is not built with every room being a negative pressure room, which is basically, it sort of has a ventilation system that is isolated, so it doesn't, it keeps any kind of respiratory particles clear. And then the team gets incomplete PPE. We don't sort of walk around in PPE, so it's based on need. And here's where, you know, we had to learn resource utilization. In the emergency department, I'm used to, every time I go in and out of a room, I get a new mask or something, just because it is contaminated. We can't do that anymore. So my little trick is that I have my, and I keep it in the back of my car, but I have an N95 mask that we have to reuse for at least, so I think the rule is we reuse it for 5 shifts or 15 patients, but I have it in like one of those Ziploc throwaway boxes, because you can, it fits in it, and you can sort of wrap the elastic bands around the outside, so it's not touching anything. And then I put that on, I put a mask on over that, I put a gown on, and then I put a face shield, and then we have gloves. And we all sort of go in together. So we limit the number of times the door opens, but also limit the number of times that we're going back and forth. So it's a team of at least 1 nurse and 1 doctor, sometimes 2 nurses and 1 doctor, just depending on how acute they are. So we've had people literally walk in with oxygen rates in the 60s, so like 62%, and normal is 100%, or at least 98% or something like that. So they're definitely working very hard to breathe. And so we kind of do everything very, very quickly in terms of getting them on oxygen, determining if we have changed our practice. Well, I think, keep saying we, but I will speak for myself. I have changed my practice just based on evidence, and really what has become like our learning in real time is anecdotes from all over the world. The emergency and critical care community on Twitter and on these social media kind of things is we're communicating with each other, because in general, no emergency physician would let someone sit with a pulse ox of 60% without running to intubate. But what we've seen over time is that those who are intubated and put on the ventilator don't necessarily do better. And that is literally the exact opposite of every single other way we would intubate, is we would intubate early and quickly to make sure that someone is oxygenating as quickly as possible. In this case, we did earlier. Now I am, it takes all my kind of grit reserve to say, no, I'm not going to sort of take over, because the evidence and the anecdotes don't point to it. But we put everybody on high flow oxygen, and we're very cognizant of the kind of high flow oxygen we do, because it can spew out more particles. So even that, it's really as much oxygen as safe for the patient, but also the team and the emergency department as a whole. And for people who are really struggling and are still able to follow instructions and all the rest, I've actually proned people, just asked them to turn and lay on their stomach to recruit more of their lung tissue and help oxygenate. And it's been, again, that's not something I would ever prior to COVID do, because, you know, one of the central mantras of emergency physicians is you keep the airway clear and patent, and you are, you know, absolutely always aware of someone's airway, because that's what we protect with everything we have. And in this way, it's like, you're gonna lay on your stomach, and I'm just gonna keep watching you, but I can't say for 100% that your airway's potential is completely open, but I can see your oxygen saturation going up, and that makes me happy, and respiratory rate going down. People walk in with respiratory rates like 65, 70. And with every sort of emergency medicine bone in my body, those are the things that we do not let sit. And in this case, we've learned that we just have to kind of support someone much more before intervention the way we would invasive intervention anyway. And then we don't really, EDs have not been built historically with clear decon areas. So like we basically kind of all are in a corner and we take off our stuff before we walk out, but then I have my Ziploc box that I put my N95 in and then go see other patients. But there's lots of hand washing, lots of gel using, lots of stuff. We've gotten better at the whole donning and doffing in with limited resources.
Thank you. So it's about 5 minutes to the end of our time. There's one last question that was posed, but, and that is, what about all the other problems that people come to ERs or EDs for? Are they still coming or not? I mean, Ted, you've made the point that that the violence hasn't gone down, but for some of the data I've seen is, at least early on, total visits were down because people are heeding the advice to stay away from the ED, but are you just providing less of other types of care?
I would just offer that what I've seen and what I understand to be true is that the pediatric emergency department, so CHOPS and CHRIS, their ED volumes are decreased. So, I mean, again, this is a population that isn't largely affected by COVID, but these institutions are preparing for overflow as well. But the volume in those spaces have definitely, and you think about it, you know, kids are home, the school fights or the falls off the chairs or falls in the streets are decreased just because there's a lot more oversight in terms of children being at home and limited in terms of where they go. I'd ask Priya in terms of the adult population. I understand that there is a decrease, but people still show up for all the other issues when it's concerning enough, when there's no other access.
Yes and no. So what's been very interesting is that overall census has been down and actually very low during like the really heavy parts of COVID. So we were only seeing COVID. But the last 2 weeks, in particular, I can say in my shifts in the ED have been really, really sick people who have stayed home because they were afraid of getting COVID. And so here's where the messaging is so important, right? The messaging in the very beginning was everyone stay home, no one go to the ER unless you have COVID, right? And it's important to sort of say, yes, we need to have the access and resources to people who are afflicted with COVID. But what it doesn't take into account is that there are still other medical emergencies, right? And I've had patients who have come in like literally having basically blown out an entire wall of their heart because they were sitting at home having a heart attack, wondering if it was important enough to go to the emergency department, right? I mean, this is where, so in the world of emergency medicine, there's a term when it comes to like what's appropriate is reasonable. Like, actually, I'm going to forget it. So Ted, correct me. It's like reasonable layperson understanding or something. It's like how somebody can understand their own symptoms as being an emergency, right? There's those of us who are medically trained who can say, yes, emergency, no. But this is how you access the emergency department, is if someone thinks it's an emergency for them. In the setting of COVID, there's just all this messaging of like, everyone say everything is geared towards COVID, but really there are people still having heart attacks and still having strokes and still having medical and surgical emergencies. And what I'm seeing in the last 2 weeks is people who have really tried hard to stay home and they're coming in so sick, and that's not helping them. But what makes me even more concerned is the people who are not, so, you know, the other populations that I focus on is the opioid crisis, and as Dr. Corbin said, people who are affected by violence and trauma. We know that they're not necessarily going to be the ones to raise their hand and say, I need help, but it's the systems who will sort of respond to them. And those systems have been sort of altered, not really altered, but kind of diverted in different ways. And I'm very, very concerned about the people who are trying to stay at home because that's what they think they're supposed to do when they really genuinely and desperately need help. And people with substance use disorders, people who are in acute withdrawal because even drug supplies are affected, and people who require medication to stay well and feel like they don't have the access, and that I am very, very worried. We don't see them, and we're not looking for them the same way as we were just 2 months ago.
So thank you. We've hit our time limit, but we have a permission to go just a minute over. Do either of you have a very brief or just short concluding comments that you'd like to make? We've covered a lot of ground. Any closing comments
I just got one
want to emphasize?
quick thing to say, and that I think where both Priya and I operate from as emergency physicians with a heart for public health, we recognize those issues that are not just, you know, an individual one-off, but it is really a population community thing. And it really, I want to emphasize how, I mean, this pandemic is terrible, and that it's done so many things and created so many different things. And at the same time, it has, you know, blatantly shined the light on these disparities that are not going away unless we pay, you know, serious attention to them. And issues of opioid addiction, issues of violence and trauma, they're still here and they're still happening. And I just emphasize how important it is for us to take this as an opportunity to really look at how we can, you know, take the best care of our patients as best as we can, patients and populations.
Thanks. And Priya, any?
So I completely agree with that. I think this is just such a unique and unbelievable in some ways, amazing in some ways, time in all of our lives. I don't think anyone has experienced something like this in our lifetime, right? And the HIV epidemic, when it first started, is probably the most recently similar, but even then it was, you know, we didn't shut down a country, and we were learning in real time. I wasn't, but my colleagues, my predecessors were learning in real time. I think what we really have to do is use all of the information and all of the data and all of the evidence that we've collected over so many years and decades to show the shortcomings of our health system, but also show the successes of other systems. And now is a time to kind of really put all of those things to work. And so this is a time where we have new graduates in an uncertain world with an uncertain future, but I implore you, all of you, this entire workforce, if ever there was a time that the entire world almost recognizes the importance of the public health workforce, is now. And I think I, as a mother of young children, I also look to you to really try and make our world and make our systems better for my children and their generation. But right this second, right now, we have to kind of let go of any barriers that we have of just adhering to the way things have always been, and really use all of our expertise and skills and experience and use our partnerships across multiple disciplines to make things better and make the changes that we know need to happen. Because while none of us have experienced anything like this, we've also never had an opportunity to, like, in my mind at least, try and blow systems up that have not been working. The time is now. So it's just all of us that are part of this workforce and all of those coming behind us. I support everything, and I try and support everybody coming behind me to try and say, like, this is it. This is our time, and this is where we can bring our skills to the forefront, and collaborate together to make these changes that are just imperative at this point.
That's thank you so much. Thanks to both of you for a really thoughtful, illuminating conversation. I hope that those of you who are in the audience that can take this to heart. And I'd like to thank everybody who's tuned in today for participating. And again, one of the downsides of being in this remote world is we can't show each other in a more demonstrative way how much we've appreciated your contributions to the program today. But thank you. And for those of you that are interested, tune in to our session next week. Take care.
Thank you so much.
Thank you. Have a great evening. Be safe.